Today's topic is a case of Schonlein Purpura. Just say we will discuss about a case with a chief complaint of the rash and pain abdomen. Here is a child you have seen rash. Now we will see the history. This is a clinical orientation of this is a video with clinical orientation. Child presenting with Henoch Schonlein Purpura like features, rash and pain abdomen. 8-year-old male child who presented with the rash over legs, that is lower limb, for 5 days, pain abdomen for 3 days, and vomiting for 3 days. The child developed rash. It starts from the lower leg on extensor surface, gradually progresses to involve the thigh and buttocks. The rash was reddish, painless, non-itchy, slightly raised from the skin surface, not associated with discharge or crusting, do not involve the palm and sole. And he also complains of pain abdomen in the epigastric region for 3 days, acute in onset, colicky in character, non-radiating, no aggravating and relieving factors. And there is also a history of the pain in the bilateral knee and ankle for 3 days associated with the swelling. Now this is all about the all positive history about the child who presented with the rash and pain abdomen. Now the child presented with a rash. Now we will deduce the history here with the rash which starts from the lower leg on the extensor surface. So this is a characteristic on the extensor surface, and it gradually progresses to involve the thigh and buttocks. It is reddish, painless, not associated with pain, non-itchy. What does it indicate? When will the rash be painful? Most likely when the rash is, if the rash is painful, it is most likely infective etiology, or for example measles and chickenpox. All those rashes, they form the vesicles, bulla, right, and papules, they are painful. Now non-itchy, itchy rashes seen in eczema like conditions, allergy, so slightly raised from the skin surface. This is important. Flat lesion is called macule and raised lesion is called papule. So in dermatology, so slightly raised from the skin surface, it has significance. It is slightly raised, it indicates there is something deposition or something has bulged out. So some deposition is there. We suspect here deposition. What type of deposition? We suspect here petechial or purpuric deposition, because we ruled out likely infective etiology because it is painless. So petechial or purpuric rash. Now petechial or purpuric rash, how it is formed? It is formed by the deposition of the extravasated RBCs outside the blood vessel, not within the blood vessel. RBCs has extravasated outside the blood vessel and they have deposited here. Now this produces the petechiae or purpurae. What could be the differential for petechiae or purpurae? One is Henoch Schonlein purpura, our today's topic. Other is immune thrombocytopenic purpura, leukemia, aplastic anemia, and drug reaction is the other differential diagnosis of a rash. Now, why does Henoch Schonlein purpura causes petechial rash? Henoch Schonlein purpura is a what actually is Henoch Schonlein purpura? What actually is Henoch Schonlein purpura? Henoch Schonlein purpura is a small vessel vasculitis. So it involves the small blood vessels like capillaries. So when it involves the capillaries, when it causes vasculitis, there is inflammation. So inflammation, there is vasodilatation. So when there is inflammation and there is endothelial injury and vasodilatation, which lead to the extravasation of RBCs outside the blood vessel. And in this deposition of the RBCs, it creates the petechiae or purpura. Petechiae is less than 0.5 cm lesion and more than 0.5 cm lesion is called purpura. Now other is ecchymosis. Ecchymosis is larger lesion, right, like a bruise. So this is how purpuric rash is formed in Henoch Schonlein purpura. The other one is immune thrombocytopenic purpura, with the name itself, idiopathic thrombocytopenic purpura. There is thrombocytopenia and purpura is formed. So due to thrombocytopenia, immune-mediated mechanism which acts against the platelet, and there is platelet number is decreased, leading to thrombocytopenia, which is called thrombocytopenia. And when there is thrombocytopenia, there is no proper clotting mechanism. So when there is a small injury, RBC can easily leak out. No clotting mechanism right there in the vessel. No coagulation pathway activating. Now in leukemia, the same is the mechanism. In leukemia, there is this leukemia is a neoplasm of WBCs, which lead to increase in the number of WBCs in the bone marrow, causing the crowding out of the other normal cell population like RBC, WBC, and platelet. When there is crowding of platelet, this causes pancytopenia, that is decreased platelet also. So decreased platelet count, same way as ITP, it causes the purpura. Now aplastic anemia is the same, and drug reaction is another differential diagnosis in our case, right? Now there is another complaint, pain abdomen. Why is pain abdomen important in this condition? Now we know that Henoch purpura is a small vessel vasculitis, that is, it causes inflammation of the blood vessel wall. Now this blood vessel wall also in the abdominal region, abdomen, in mesenteric blood vessels, it also causes inflammation. When it causes inflammation in the mesenteric blood vessel, it leads to various complications. For example, when there is inflammation of the wall of the, there is mesenteric blood vessel supplying the intestine. Now when there is inflammation, it causes necrosis of the abdominal wall. So when there is necrosis of the abdominal wall, there will be bleeding, right? When slugging of the wall causing leading to bleeding, or when there is vasculitis, it act as a, when there is vasculitis, there is edema, so it acts as a leading point leading to the intussusception. What is intussusception? There is telescoping of the proximal segment. Here vasculitis, so peristaltic wave is coming, and now it acts as leading point due to edema, right? And this proximal segment, that telescopes into the distal segments, that is called intussusception. These are the complications of vasculitis, that is Henoch purpura in the mesenteric blood vessel. So first we describe the rash. How we describe the rash? It is how it progresses, from where it progresses. Any prodromal symptoms like fever. If there is fever, we could identify it as on what day of the fever the rash has appeared. That is a different topic. So again, from where it started, and how it involves the body parts, and what is the color, reddish, and painless or not, if there is any pain or not, non-itchy, and slightly elevated from the skin surface, and associated with discharge or crusting or not. After asking all this, we ask if it involves the palm and sole. There is a particular type of, in some diseases it involves the palm and sole, and most diseases it spares the palm and sole. Rashes spare the palm and sole. The diseases that involve the palm and sole is typhus fever. So in tropics, if the child presents, if anyone presents with rashes also involving the palm and sole, so we could suspect it is a case of typhus fever. Now pain abdomen, we discussed, it could be the complication of the Henoch purpura involving the mesenteric blood vessels. Now bilateral knee arthritis is the other complication of Henoch purpura. The child presented with the arthritis features. Now other important is fever. Is there a fever? If there is fever, then we should think of the different line of diagnosis, and if there is no fever, we should think of the different line. Now in our case there is no fever, so we think of all these. Now if there is fever associated with purpuric or pruritic rash, what could be the diagnosis in a child? What could be the differentials in a child? Most important is meningococcal sepsis. When there is meningococcal infection caused by the meningococcal meningitis, it causes meningococcal meningitis. When there is infection of meningococcus meningitis, there is rash appearing in the body parts, limbs. So if there is fever, we could suspect that, along with the neck rigidity and various features, meningeal signs, shrill cry in the child. We should or include all those in the history. Now other are viral hemorrhagic fever, yellow fever, leptospirosis, malaria. In all these tropics, they could be the differential diagnosis for the purpuric or petechial rash. Now after fever, we should also ask about the complications of the Henoch in purpura. We asked about the pain abdomen. The child has positive history. Now other complications that could be present are nephritis. In nephritis, right? Nephritis For nephritis, it's a nephritic syndrome. Present with nephritic syndrome, it could be red colored urine. Nephritic syndrome simply presents with red colored urine for the urine due to increased protein loss and loose stool, black tarry stool, blood in stool. All this for the intestinal perforation. I said because there is inflammation of the mesenteric blood vessel leading to the ischemia or necrosis, and slugging of the wall leading to the bleeding, and the child present with black tarry stool. If it is a case of induced assumption, another complication apart from the perforation in the GIT, the child presents with current jelly stool like a current jelly. Now, is no issue of drowsiness, seizure. We should ask this because other complication is CNS vasculitis. It involves the renal, GIT, the CNS involvement. CNS vasculitis. For this, we should ask drowsiness and seizure. Gum bleeding, epistaxis. For our differential diagnosis, what we thought of? ITP, leukemia, aplastic anemia. All these three, there is thrombocytopenia. If the person has thrombocytopenia, then bleeding will be from the other body parts, right? Gum bleeding, epistaxis, they may present. Now, history of the frequent infection, fatigue, or palpitation. I asked this for aplastic anemia and leukemia. Why? Because in leukemia there is decreased WBC count. Both aplastic anemia and leukemia decreased WBC count, decreased RBC leading to anemia, which presents with fatigue and palpitation. This is also a feature of anemia, right? Anemia in severe case even can present with the congestive heart failure because there is high volume, high pulse volume is present because there is decreased blood volume in case of anemia. So palpitation and fatigue, they are present. Now any drug use and radiation exposure for our differential diagnosis aplastic anemia, and also the drug use for drug reaction. Now aplastic anemia is caused by drugs like alkylating agents, cytotoxic drugs in chemotherapy, and chloramphenicol is other common drug which we use in the simple gastroenteritis. So it could be the other cause for long. If they are using these drugs for a long time, then the child may have bone marrow suppression. When there is bone marrow suppression, there will be decreased platelet count, and child may present with a purpuric rash. This is all about. Now this is all about history, right? Now we're going to discuss on examination of the same child. On examination of the rash, we will do diascopy. What is diascopy? There is nothing. Its name is as fancy as it is. There is nothing complex about this reaction. We use the glass slide, and we press against the rash. So when we press against the rash, if it becomes non-blanchable, that is, if there is blood vessel here and there is RBC deposited outside the blood vessel, even if we apply pressure from the above, the RBCs won't get returned to the blood circulation. So purpuric rash will be non-blanchable. But if the rash redness is due to the dilated capillaries, the RBCs are within the capillaries. So if we press from the outside, this RBC will get shifted and the redness will goes away, it blanches. So we will distinguish the purpura from the telangiectasia. Telangiectasia is simple vascular dilatation. So purpura is extravasated RBC. This is how we differentiate by diascopy purpuric rash or telangiectasia. Now liver and spleen are not palpable. Now in investigation, this is very important. The patient has normal platelet count. Why it is important? in all of our differential diagnosis, there will be decreased platelet count. But in case of Henoch purpura, the purpura formation is not due to decreased platelet count. It is the vasculitis that causes purpura formation. So normal platelet count, we say it is non-thrombocytopenic palpable purpura is a pathognomonic. Thrombocytopenic palpable purpura is a pathognomonic feature of Henoch purpura. Now we can do skin biopsy because IgA deposition occurred in this case. This is diagnostic. Urine RBC protein for nephritis component or complication. Renal function test same. And ultrasonography for GI lesions in this assessment. Now this is all about Henoch purpura investigation. So to rule out the other causes like leukemia and aplastic anemia, if we suspect, we can do peripheral smear, and blast cell more than 20 is diagnostic in ALL. Aplastic anemia, RBC, WBC, platelet count all decreased. Then bone marrow biopsy can be done, and in aplastic anemia there will be dry trap because no precursor cells are present. Aplastic name also it is given, no precursors. It is actually a misnomer. It should be aplastic pancytopenia. So there is no bone marrow precursor cells. So the person will be at the bone marrow biopsy procedure will be dry. You won't get a proper biopsy, and all cell population it will be decreased. Aplastic pancytopenia I have said. Reticulocyte count is normal or decreased. Whenever there is anemia, there will always be increased reticulocyte count. Why? Because bone marrow will try to produce more and more blood cells, but in this case already a precursor cells are less, so reticulocyte count will be less. These are the tests: peripheral blood smear and bone marrow biopsy. They are to rule out the other possible differentials. This is all about the this is all about the history, examination, and working of this patient. Now, what is Henoch purpura? Is I have already told you it is a IgA vasculitis. It is a small vessel vasculitis. It involves the small vessel. Small vessel could be pre-capillary arteriole, capillary, and post-capillary venule. First artery comes, then it divides from the arteriole. So it is also a small vessel. Now it again divides from the capillary and it gets unite from the venule. So pre-capillary arteriole, capillary, and post-capillary venules. All three they are small vessels. Now in this case there is inflammation involving all three vessels. Right? It is a small vessel vasculitis. The IgA, also known as IgA vasculitis, because it occurs due to IgA deposition. It is most common small vessel vasculitis in the children. Now it has a diagnostic criteria. Before going that, we will discuss other things about the vasculitis. It is preceded by the mucosal infection. So when there is mucosal infection, the local immunity kicks in. So when the local immunity kicks in, the IgA levels will be increased, right? Mucosal infection like upper respiratory tract infection, GI infection, and other are urinary tract infection. They are all mucosal infection involving the mucosa. So it may be preceded by the mucosal infection. So mucosal infection produces the IgA, but not everyone, because not everyone with mucosal infection present with Henoch purpura. There should always be this pathogenesis process going on within the person to produce the disease, right? What is this pathogenesis? This is defective. This is IgA immunoglobulin A. This is the heavy chain. This is the light chain, and this is the hinge region. We call it SS disulfide bond was present. So this hinge region, there will be defective glycosylation in this disease person predisposing. There will be defective glycosylation. So when there will be defective glycosylation, this whole IgA it acts as foreign antigen to our own body. It's kind of autoimmune disease. So against our own antibody, our body produces other antibody. So IgA and IgA acting as antigen and our body producing the autoantibody, right? They form the antigen antibody complex. So this antigen antibody complex simply get deposited. Now this antigen antibody complex when it gets deposited in the small blood vessels, there will be complement activation and inflammation process going on, right? When there is complement activation and inflammation process going on, based on where the this complex antigen antibody complex deposited, there will be different lesions. For example, it involves skin, kidney, GIT, and joint. When it involves the skin, it causes palpable purpura. I have already said vasculitis, inflammation, vascular wall damage leading to extravasation of RBC. Extravasation of RBC produces petechia. First of all, there is macule, then petechia, then purpura or ecchymosis when there is in the late cases. Now, the important part is it is present in the gravity dependent areas and pressure points, right? Extensor surface, gravity dependent area, pressure points. This it involves those sites. Henoch in purpura involves those sites. Usually symmetrical on both limbs. It present in the crops for 3 to 10 days. And it can recur up to 4 months. This is the skin lesion. Now kidney, this same antigen antibody complex produced which was formed by the immunoglobulin A, defective immunoglobulin A due to defective glycosylation, plus autoantibody, that is antibody against our own antibody, right? This complex first deposit in the skin, then in the kidney. When it deposits in the kidney, again complement activation, inflammation, glomerulonephritis, the kidney inflammation. Only one third of the cases present will progress to or will involve the kidney, not more than one third, right? One third of the cases we will see involvement of kidney. Other is GIT, already said, mesenteric vasculitis, ischemia which lead to the pain. Whenever there is ischemia, there is pain. And perforation, ischemia again lead to perforation. In-tube susception, edema, vasculitis is leading point, and arthritis. That is, it involves less than 4 joints, oligoarthritis. Skin, kidney, GIT, and joints. Right? We could remember it as skin first here, purpura, then joint, near in lower joint here is knee joint, skin, joint, and there is kidney and GIT. Based on all these four features, and again from the lesion biopsy, there is a diagnostic criteria for IgA vasculitis, which was given by Euler, European League Against Rheumatism and Pediatric Rheumatology, European Society. Euler gave the diagnostic criteria, which indicates one is the mandatory criteria, other are 4 other criteria. Mandatory criteria is I have said is a pathognomonic lesion, which is purpura or petechia with lower limb predominance. It is more commonly present in the lower limbs because gravity dependent area, pressure points. It involves the gravity dependent area and the pressure points. So purpura or petechia with lower limb predominance is the mandatory criteria, and minimum one of the 4 criteria should be present to diagnose it as Henoch purpura. 1, 2, 3, 4. If any one is present, then we could diagnose it as Henoch purpura. One is arthritis or arthralgia of acute onset, diffuse abdominal pain with acute onset, abdominal pain is diffuse, and histopathology and biopsy, leukocytoclastic vasculitis. Leukocytoclastic vasculitis should be present in the histopathology, or kidney biopsy shows the proliferative glomerulonephritis with the IgA deposition. Proliferative glomerulonephritis with IgA deposition. And renal involvement and with evidence of renal involvement, that is protein or RBC should be present, right? There is not more complex. Mandatory criteria comes from the skin and all these 4 organs: kidney, GIT, and joint and skin. Other these 4 criteria again repeated in the along with skin. It was present in the other criteria. So mandatory criteria, other criteria, mandatory criteria, skin, palpable purpura, and other criteria, one of the 4 should be present. One is arthritis, arthralgia of acute onset, diffuse abdominal pain of acute onset. Other is biopsy histopathology showing the leukocytocytic vasculitis. You should remember this term, leukocytocytic vasculitis. And renal involvement. Renal involvement, there will be evidence of proteinuria or hematuria, that is nephritic syndrome. This is how we diagnose Henoch purpura. And I have told you that mucosal infection, all mucosal infection does not cause Henoch purpura in actual. And in what person? Only in predisposed person, when there is mucosal infection, it triggers the Henoch purpura, right? Because there is increased IgA, and in a predisposed person there is already a defective IgA, so defective IgA population will increase, and there will be increased deposition along with combination with our autoantibody. So when there is increased deposition, there will be vasculitis predisposition by vasculitis presentation, right? This is why the person with predisposing person, whenever there is mucosal infection, preceding mucosal infection, so we can ask it in the history. If there is any predisposing mucosal infection like upper respiratory tract infection, urinary tract infection, and GI infections. So pathogenesis we have talked. Yeah. And renal involvement, most of renal involvement they are within the 1 month, almost all by the 3/6, and total 1/3 only present with renal involvement, 20% with the severe nephrotic or nephritic syndrome, severe indicating significant proteinuria, protein creatinine ratio more than 1, urine protein more than 1 gram per day, and significant hypertension and increased serum creatinine. If the person present with these features, right, severe nephritic features, then renal biopsy is indicated. These are the indication for internal biopsy. We treat by hydration, analgesic, because pain abdomen there will be there, mesenteric vasculitis. Steroids should be given only in case of severe GI and severe joint involvement. Thank you so much for watching. This is all about Henoch purpura.